I have no financial disclosures here. And we'll play this. So to explant a lens, the old way we've been doing it, cut it in half, and that certainly works really well. Sometimes I'd even put in the new lens first to protect the capsular bag, because I found out a hard way, don't ask, that these scissors, if they touch the posterior capsule, it'll break it. So this, you can cut the lens 80% the way through. This requires, of course, special instrumentation. These aren't on your everyday tray. And if you're like me teaching residents at a county hospital, it's very difficult to buy $5,000 or $10,000 of specialized instruments in order to accomplish this. But this certainly works well. Here I cut it mostly in half, and then just bring out one half, twist it around, and we can pull out the other half, and then you have the lens that's there. But of course the lens has been cut, so it's damaged. We can put the new lens in thereafter, and this can be done through your normal 2/8 or whatever size phaco incision. So there's the lens. That's traditional. So a different technique is this, to twist it within the eye and then explant it. Let me show you. It's something I learned from Jack Chapman from the Atlanta area. So he's the genius who's behind this. Grabbing the lens with straight tying forceps, eccentrically grab the edge of it. In the left hand or non-dominant hand is a cyclodialysis spatula. You're watching a resident do this. This is a senior resident. So we just put the spatula there to help roll the lens and also protect the corneal endothelium. Obviously the anterior chamber is full of viscoelastic. And now we just twist the tying forceps, which will curl up the lens, and you pull it out your 2/8 incision. Yes. I'd love to take the credit. Again, it's Jack Chapman who's the genius.
That is nice.
Here's the external view. While the resident was doing it, this is me on my iPhone. Let me show you that one more time in slow motion. So again, twisting it, and then the spatula protecting the corneal endothelium, and you rotate it, and then once you got it pretty much twisted, just pull it out of the eye. So that works great. Let me show you a couple more videos of the same thing. This is an old video. You can tell the low resolution on it. So we did this with residents years ago. Now this is a bent forceps, a curved forceps. That obviously is very awkward. So use the straight tying forceps. But same concept, roll it in the eye, spatula to help roll it and to protect the cornea. And then once you get it around, just kind of give it a good pull, it'll come right out. It doesn't matter if it's not totally tightly formed, because once you start to pull it out of the eye, even if the distal end of it is a looser cone, it'll still come out. So again, grabbing it eccentrically here. So not in the center, grabbing it eccentrically. And then the spatula here is to protect. So bring the lens, and you saw I have one haptic already outside the eye. That helps orient things. And so the lens has obviously been dissected already. Spatula goes on top, and then again, twist, and once you get it curled up sufficiently, you can just pull out of the eye. Now you may have to twist your hand, so the easier way of doing this is going in with the hand already pronated and then supinated. If you go in straight, you'll only get half the turn, and you'll have to repeat it. Now some of the lenses, we have done calcified lenses as well. If there's a dense calcification, keep in mind that those calcium particles make the lens hard. And the lens is less flexible and less able to be rolled like this. In fact, they're sometimes harder to even cut. But it can be done, and we've done it for opacified lenses as well. And again, this technique works really well, certainly in resident cases, and residents now do this on their own after watching the video. And all the videos, by the way, are up on my teaching website, which is listed there. It's a free website. We put a new video every day. So there we go at the end here. And in this case, I'm going to put a new lens in. And so I just want to show you one more technique here. Put the new lens. The capsular bag is actually intact, but the leaflets are very fused together. So we're going to choose to put the lens in the sulcus. So putting some cohesive viscoelastic just to open up the sulcus a little bit. And even though the pupil's small, what we can do is have the lens inserted, and I'll show you what we'll do. Put the 3-piece lens on top of the iris initially. Don't worry, we won't leave it there. And then we'll dial it in. But this is important, again, opening up the sulcus all around. Here comes the 3-piece lens. And looks like a left-handed surgeon. Maybe it's my left-handed resident. So deliver the lens. The lens obviously goes, in this case, we'll put it in the sulcus, but I'm going to start off with it just on top of the iris. And that just makes it a lot easier to see where it's going. Then it's very easy to just dial it in gently. And then at the end, the chopper can be used to lift up the iris to confirm its position. So we'll just dial that in. So if you have a case like this, you need to do lens exchange. Certainly with our most commonly used lenses, these single-piece acrylic lenses is a really neat technique. Does also work with other lenses, works with the 3-piece acrylic lens. Silicone lenses does work too, but the problem is silicone lenses, once they're coated in viscoelastic, are really slippery. And so that makes it a little bit more difficult to remove them. So here in this case, the resident is going to dial the lens in and we'll be done. So once again, a thanks to Jack Chapman from Atlanta for his idea behind this. I learned it 10 years ago at a different meeting, and I've used it many, many times with my residents. I thought it's something I should refresh your memory with. Any comments or input from the panel while the video is played out?
So clearly an audience favorite. Good job. My question is, and I might have missed it, but it looked like most of those were yellow lenses, and so I assume that they were Acrosoft. But what about Sensar material or the Bausch & Lomb? They seem to be a little bit thicker. Will they roll up like that too?
Right. So we've done the ZC Blue lens. I've done the 3-piece Technics lens as well. I have not yet expanded an Invista lens, which is a little bit thicker. We've done hydrophilic acrylics as well. They're usually no issue. And so I think it should work in a similar manner. You can certainly enlarge the incision a little bit more if you need to.
Particularly compelling that a lot of these are resident cases, and it's an advanced technique and it seems to go well. What about putting posterior pressure on? Do you find that residents have a tendency to push down too much and bring vitreous with them as they're pulling that lens out, or not really?
So again, it depends on the case, depends on the resident, but you can see I have a pretty good level of confidence if I'm sitting there with my iPhone doing the external view while the resident's actually doing the case.
Very good.
I just do the coaching part of it. The residents are actually the hands.
Very good.
So thank you guys.